Hello, I'm Professor Peraza, and today's lecture video covers body composition, weight management, disordered eating, and eating disorders. These are the specific learning objectives for this module. After this lecture, you will be able to describe what metabolism entails, identify the metabolic pathways that are involved in the production of ATP from the macronutrients, recognize the effects of feasting and fasting states, describe methods that could be utilized to assess body composition, identify behavior management strategies that contribute to weight management and overall health, and identify health risks associated with disordered eating and eating disorders. This module also meets the following course learning objectives. Let's start first with metabolism. Metabolism includes the chemical processes involved in maintaining life. With metabolism, we have what's called metabolic pathways. These are groups of biochemical reactions and include glycolysis and beta oxidation. Intermediates are compounds that are formed in one of the steps involved in a metabolic pathway. Metabolic pathways are further classified as anabolic or catabolic. Anabolic are those that use smaller compounds to build larger ones. An example would be storing glucose as glycogen. This pathway requires energy. Catabolic would be breaking down larger compounds into smaller ones. An example would be breaking down glycogen to fuel the body with glucose. In this case, energy is released. The catabolic reactions, breaking down, begin with digestion and then continue when the smaller building blocks are sent through metabolic pathways to yield energy. Your body strives for balance between anabolic and catabolic processes. Adenosine triphosphate, or ATP, is the energy form that our bodies can use. ATP is an energy-carrying molecule found in the cells of all living things. ATP captures chemical energy obtained from the breakdown of food molecules and releases it to fuel other cellular processes. ATP is made up of adenosine bound to 3 phosphate groups. These bonds contain energy. Our cells break apart these high-energy phosphate bonds to release energy. ATP is constantly being broken down and formed in the body, which this recycling process is essential for survival. We can only store a small amount of ATP at a time, so we need to break down and resynthesize ATP for transferring energy from one location in the body to another. ATP, when broken down, yields ADP and free inorganic phosphate groups. ATP is then regenerated by adding phosphate back to ADP and AMP, which is adenosine monophosphate. The majority of ATP synthesis occurs in cellular respiration within the mitochondrial matrix. Many processes are capable of producing ATP in the body. ATP production can occur in the presence of oxygen from cellular respiration, beta oxidation, ketosis, lipid and protein catabolism, as well as under anaerobic conditions. Aerobic versus anaerobic metabolism. Aerobic metabolism takes place in the mitochondria of the cell and is able to use carbohydrates, protein, or fat as fuel sources. Aerobic metabolism is a much slower process than anaerobic metabolism, but it can produce much more ATP, and it is the process by which the majority of the ATP in the body is generated. With aerobic metabolism, oxygen is available. Oxygen is essential for energy metabolism to continue, and without it, metabolism stops and death occurs. Anaerobic metabolism occurs in the cytosol of the muscle cells. A small amount of ATP is produced in the cytosol without the presence of oxygen. Anaerobic metabolism uses glucose as its only fuel source and produces pyruvate and lactic acid. Lactic acid is carried to the liver, where it can be converted to pyruvate or glucose via the Cori cell. Pyruvate can then be used as fuel for aerobic metabolism. Pyruvate can then be converted into lactic acid, and in this reaction, lactic acid replaces oxygen as the final electron acceptor. Red blood cells, for example, lack mitochondria, so they must produce ATP from anaerobic respiration. Cellular respiration is the process of breaking down glucose into acetyl-CoA and yielding ATP. There are a few key steps in cellular respiration. First is glycolysis, which is when one molecule of glucose is broken down into 2 pyruvate molecules. This step, oxygen is not required. Through glycolysis, 2 ATP are utilized and 4 ATP are generating, meaning there's 2 net ATP produced along with 2 pyruvate. In the presence of oxygen, pyruvate continues on to the Krebs cycle, also called the citric acid cycle or TCA, where additional energy is extracted and passed on. To start the Krebs cycle, citrate synthase combines acetyl-CoA and oxaloacetate to form a 6-carbon citrate molecule. CoA is released and can combine with another pyruvate molecule to begin the cycle again. For each turn of the cycle, 1 ATP is produced. Each carbon of pyruvate is converted into carbon dioxide, which is released as a byproduct of aerobic respiration. Next up is the electron transport chain, where electrons are further transferred. Electrons, oxygen, and hydrogen combine to form water. This is the basis for your need to breathe in oxygen. For every glucose that enters aerobic respiration, 36 net ATP are produced. For ATP production from fats, this process first starts with lipolysis, which is where triglycerides are broken down into fatty acids and glycerol. The fatty acids are then oxidized by beta oxidation into acetyl-CoA. The acetyl-CoA can then be oxidized in the Krebs cycle. The fatty acids for beta oxidation can come from dietary fats or fats stored in the adipose tissue. When glucose levels are plentiful, the excess acetyl-CoA generated by glycolysis can be converted into fatty acids, triglycerides, cholesterol, steroids, and bile salts in a process called lipogenesis. When you eat more glucose or carbohydrates than your body needs, your system uses the acetyl-CoA to turn the excess into fat. Triglycerides and lipids, high energy molecules, are stored in adipose tissue until they're needed. Let's talk about ketogenesis. If there are an excessive amount of acetyl-CoA produced and the Krebs cycle gets overloaded, the extra acetyl-CoA is diverted to create ketone bodies. With a low carbohydrate diet, oxaloacetate is the first molecule to combine with acetyl-CoA in the Krebs cycle to form citrate to start the cycle. With oxaloacetate being inadequate, the Krebs cycle decreases, but lipolysis continues. This acetyl-CoA builds up and forms ketone bodies as a byproduct. Most ketone bodies can be converted back into acetyl-CoA and re-enter the Krebs cycle and be used for fuel. Ketone bodies can serve as an energy source if glucose levels are too low in the body. This is a crucial mechanism during a period of prolonged starvation or with uncontrolled diabetes. In both cases, fat storages are utilized to generate energy through the Krebs cycle and will generate ketone bodies when too much acetyl-CoA accumulates. Over time, the brain can use ketones as an alternative energy source from glucose. Ketones can be excreted in the urine, but if ketone production is very high, they begin to accumulate in the blood in a condition called ketosis. Symptoms of ketosis include sweet-smelling breath, dry mouth, and reduced appetite. Now, with nutritional ketosis from a low-carbohydrate diet like the ketogenic diet, ketone bodies are produced in a small concentration without altering blood pH. Ketones are acidic, so with severe ketosis, the blood becomes too acidic, leading to ketoacidosis. With ketoacidosis, ketone bodies are produced in an extremely large quantity, leading to an alteration in blood pH. With diabetic ketoacidosis, if insulin is not present, like due to type 1 diabetes or a missed dose of insulin with type 2 diabetes, the cells are not able to utilize glucose in the bloodstream. Rapid lipolysis occurs, and ketone bodies are produced in excessive amounts. These ketone bodies spill over into the urine and pull electrolytes like sodium and potassium with them. This leads to ion imbalances. DKA can happen quickly in less than 24 hours and lead to coma and death. Treatment involves fluids, electrolytes, and insulin. After digestion, amino acids are transported across the intestinal mucosa to be used to create new proteins or to be converted into fats, glucose, ketones, or acetyl-CoA and used in the Krebs cycle. Proteins are not stored for later use, so excess proteins must be converted into glucose or triglycerides and used for energy or to build energy reserves. Extra amino acids are also decomposed if not utilized elsewhere, and this can result in nitrogen waste, which is in high amounts toxic. Now, with gluconeogenesis, which is the pathway of producing glucose from non-carb substances, this can be accomplished via some amino acids or the glycerol portion of a triglyceride. The fatty acid portion of a triglyceride cannot be turned into glucose, only acetyl-CoA. With glycerol, an insignificant amount of glucose is produced via glycolysis. So far, we've been talking about aerobic cellular respiration, which is when oxygen is available. Let's cover anaerobic cellular respiration, which is when oxygen is limited or not available. In this case, pyruvate, produced during glycolysis, is then reduced to lactate. Lactic acid replaces oxygen as the final electron acceptor. Anaerobic cellular respiration is an effective pathway of ATP production for a short period of time, a few seconds to minutes, and can be utilized when mitochondria are also absent. The lactic acid is carried to the liver and then converted to pyruvate or glucose via the Cori cycle. This anaerobic metabolism is crucial in the beginning stages of exercise when the muscles use ATP quicker than oxygen can be delivered. Your muscle cells rely on glycolysis and lactic acid production for quick production of ATP. Energy metabolism is regulated by hormones, enzymes, ATP concentrations, vitamins, and minerals. Cortisol, glucagon, and epinephrine, for example, are catabolic hormones, stimulating the release of energy. Insulin, estrogen, and testosterone are examples of hormones that are anabolic, stimulating energy storage. High ATP concentrations will decrease energy-yielding reactions like glycolysis, and high ADP concentrations stimulate energy-yielding reactions like gluconeogenesis and lipolysis. Many vitamins and minerals are needed for metabolism, like B6 for the conversion of glycogen to monosaccharides, or niacin to convert ethanol to acetyl-CoA, or niacin, biotin, and folate for amino acid formation. Enzymes are also key regulators of metabolic pathways, with their presence and rate being critical for chemical reactions in the body. We talked about metabolism, and we're going to cover the absorptive and postabsorptive states. The absorptive state, or the fed state, occurs after a meal when your body is digesting the food and absorbing the nutrients. This absorptive state can last up to 4 hours. During this time, glucose levels rise, insulin is released by the pancreas, and glucose is stored as glycogen in the liver or muscle cells. Any excess fats, sugars, or proteins, if not utilized, will be stored as triglycerides in adipose tissue. The post-absorptive state is also known as the fasting state, and this occurs once the food has been digested, absorbed, and stored. Initially, the body relies on stored glycogen. Eventually, gluconeogenesis begins to replace glucose used by the peripheral tissues. Certain key organs, including the brain, can only use glucose as an energy source. Therefore, it is essential that the body maintain a minimum blood glucose concentration. After an extended period of time, the body goes into survival mode, in which the first priority is to still provide enough glucose to fuel the brain. It is also a priority to conserve amino acids for proteins. At this point, the body uses ketones to sustain energy needs. After several days, ketone bodies are the primary fuel source for the heart and other organs. Fatty acids and triglycerides continue to be utilized to create ketones. The body tries to conserve glucogenic amino acids. Eventually, fat storages are depleted and proteins from muscles are released and broken down for glucose synthesis. Survival is dependent upon the amount of fat and protein stored in the body. Metabolic rate. This is the amount of energy consumed minus the amount of energy expended. The basal metabolic rate, or BMR, describes the amount of daily energy expended by humans at rest in a neutrally temperament environment while in the post-absorptive state. Your BMR is the energy needed for normal basic functions of the body and is about 70% of energy expenditure. The remaining 30% is expenditure with physical activity and thermoregulation. There's a lot of misinformation out there when it comes to boosting metabolism. Yes, there are factors that can increase or decrease metabolic rate. For increasing metabolic rate, this includes greater muscle mass, body temperature, higher than normal secretions of thyroid hormones, nervous system activity, growth stages, and recent exercise. For decreasing metabolic rate, This includes lower than normal secretions of thyroid hormones, restricted calorie intake, less muscle mass, and aging after the age of 30. The thermic effect of food is the energy needed to digest, absorb, and store the nutrients in foods. It accounts for about 5 to 10% of total energy expenditure. Adaptive thermogenesis is defined as the regulated production of heat in response to environmental changes in temperature and diet, resulting in metabolic inefficiency. This is a small contribution to energy expenditure. It involves non-voluntary physical activity like shivering due to extreme cold. Let's talk about the body mass index, or BMI. The BMI is simply a mathematical calculation that takes a person's weight in kilograms or pounds and divides this by the square of height in meters or feet. According to the CDC, a high BMI can indicate high body fatness. BMI screens for weight categories that may lead to health problems, but it does not diagnose the body fatness or health of an individual. The BMI is considered the preferred weight for height standard because it is more closely related to body fat and easier to measure. It is important to note that the BMI does not measure body fat directly, and its primary use is as a screening tool. An individual can have a high BMI but have a large proportion of lean mass like muscle tissue. Also, the BMI does not show the location of body fat in the body, which is a factor in determining health. It also does not provide specific information about the body fat or an individual's health status. It is imperative that when looking at BMI, any diagnosis is made with further assessments. This means evaluating an individual's diet, activity level, family history, body fat assessment tools, and labs. The BMI should not be utilized as a diagnostic tool, especially with children, pregnant individuals, or older adults. For pregnancy, weight gain also includes placental and fetal tissue. An older adult might have a normal BMI, but really have a high body fat percentage and low muscle mass. An individual might be considered overweight, but be active and metabolically healthy. The BMI is not particularly useful for comparing one individual to another, or even one population to another, because this one number simply doesn't account for all the underlying diversity in factors like body type, muscle mass, biological sex, and race. According to the American Journal of Clinical Nutrition, the recommended body fat ranges are for individuals between 20 and 39 years old. Women should aim for 21 to 32% of body fat. Men should have 8 to 19%. For people 40 to 59, women should fall between 23 to 33%, and men should fall around 11 to 21%. If you're aged 60 to 79, women should have 24% to 35% body fat, and men should have 13 to 24%. Let's review different ways to measure body fat. The first is the skin fold test. This is a simple, non-invasive, and low-cost way to assess fat mass. Calipers are used to measure the thickness of the skin on 3 to 7 different parts of the body, and these numbers are then entered into a conversion equation. The accuracy of this test is very much dependent on the skill of the individual taking the measurements. There is a large error margin if someone is not well trained in using the calipers. Bioelectrical impedance analysis, or BIA, is a non-invasive tool that can estimate body composition by sending a small amount of electricity through the body. Since water is a good conductor of electricity and lean body mass contains more water than fat, the rate at which the current travels can be used to estimate body fat percentage. Body fluid levels must be normal with the BIA, which is a limitation since hydration can be impacted by exercise, alcohol, and menstrual cycles. Next is the ADP, which is a tool that is more accurate than the BIA, but expensive and not always accessible. An individual sits in an enclosed chamber, usually called the bod pod, and the changes in air pressure are used to determine the amount of air that is displaced in the test chamber, which can determine body volume, and then this information is translated into body fat percentage. Lastly, the DEXA, which involves a low dose of radiation to assess body fat and also body density. Some individuals have a DEXA scan done to investigate whether or not they have osteoporosis. This is the most accurate method for determining fat mass. However, this again may not be accessible to an individual and also can be expensive to have done. Body fat distribution is another consideration when assessing health status. The location of fat is important because people who store fat more centrally or apple-shaped have a higher risk for chronic disease like cardiovascular disease and type 2 diabetes, compared to people who store fat in the hips, thighs, and buttocks, which are pear-shaped. Body fat distribution can be measured by waist circumference and waist to hip ratio, both of which only require a measuring tape. Abdominal obesity is defined by the World Health Organization as a waist to hip ratio above 0.9 for males and above 0.85 for females. When thinking about weight loss, weight management, or even weight gain, there are a few key areas to keep in mind. The first is with lifestyle. Any change in someone's routine should be looked at through the lens of sustainability. Many individuals can follow a diet and lose weight. However, oftentimes, these changes are not maintained over time due to the restrictiveness of the program. In thinking about making a change with your health, consider first your nutritional intake. What foods do you regularly consume? What gaps do you see with your intake? Regular activity should also be a component of any healthy lifestyle in whatever form suits your level of fitness and goals. Managing problematic behaviors are also crucial to success. It takes time to develop healthy habits and break those that are not contributing to health. Lastly, working with a healthcare professional can be helpful in working through behavior change. A healthcare team can include, but not be limited to, a registered dietitian, primary care physician, therapist, and personal trainer or physical therapist. Let's review some behavior change strategies. First is chain breaking, which involves analyzing your behavior and then separating behaviors that typically occur together. Analyzing behavior chains is a good way to understand more about your behaviors and to pinpoint how to change unwanted habits. An example could be looking at your nighttime routine. Let's say after dinner, you get bored and go to the kitchen to get a snack, you grab some cookies and then start eating from the box. After some time, you realize half the box is gone. You might even feel guilty and upset with yourself. Looking at this set of events, there are a few ways to separate and break the chain. First, once bored, think about if you are truly hungry or if this is just appetite. Then, if truly hungry, choosing a healthy snack or choosing the cookies but portioning them out versus eating from the box mindlessly. You could also substitute the cookies with a beverage like hot tea if not truly hungry. If the portions were overboard, perhaps looking at some reframing for the event, which involves addressing the guilt. Next is stimulus control, which is a cue or cues that encourage a undesirable or desirable behavior. If you open the cabinet when you're hungry and the first thing you see is candy, you might be more prompted to grab a handful first. What about in the fridge? What is at eye level? Chopped up fruits and vegetables, cake? Consider ways to set up your home and work environment to maximize healthy behavior stimuli. Self-monitoring is a recording behavior as a method to change behavior. Self-monitoring can be a great way to build awareness about your habits, what's working, what's not working, and also measuring and tracking progress. Self-monitoring can include keeping a food journal, tracking days you exercised, or keeping a mood journal. Smartwatches can also be another method of self-monitoring where you can keep an eye on your movement and your sleep pattern. Contingency management is basically a backup plan. Let's say you plan to exercise outside when it's raining. Your backup plan is to do a home workout. Maybe you had a family party coming up and you're concerned about overeating. You come up with a plan to address how you might manage the situation. Lastly is cognitive restructuring, which is noticing and changing negative thought patterns. This is a technique often used in a therapeutic setting and is focused on staying in the present and applying a problem-solving approach. The idea is to identify an unhealthy thinking pattern and reframe or replace the thought with something that's more effective. An example could be if someone says, "I can't believe I ate the cake, I'll never lose weight." Reframing or restructuring could look like, "I ate the cake and it tasted good, I don't do this on a regular basis, and I can continue with my healthy eating pattern for dinner." With cognitive restructuring, you want to think about the progress, not shortcomings, and try to avoid getting discouraged by an occasional setback. Let's talk about the trans-theoretical model, or stages of change. The stages of change model was developed by Prochaska and DeClement and looks at the decision-making of an individual. This model highlights the idea that individuals do not change behaviors quickly and that behavior change is really more of a cyclical process. With the first stage of pre-contemplation, an individual may be unaware that they have a problematic behavior producing negative consequences or may not be ready for change. Someone might say, I can't or I won't change. Most individuals at this stage do not intend to take action in the next 6 months. The negatives or cons of making a change are higher than the pros. With the second stage of contemplation, individuals are aware of the problem and begin to consider change, usually within 6 months. They often say things like, I may change. At this stage, someone is often ambivalent or on the fence about change. The pros and cons are equal for change. In the third stage of preparation, an individual is ready to make the change and is planning the actions they will take. Typically, they intend to take action within 30 days. Some individuals may have already started to take small steps. At this point, the pros start to increase and change becomes more desirable. Someone might say something like, I found the gym I can go to, or I will eat more vegetables. Next is the action stage, where an individual has recently changed their behavior, but it has been less than 6 months. This is the I am stage. An individual is continuing to practice their behaviors and set new habits. Their pros continue to increase and separate from the cons. Some people might say things like, I am exercising 3 days per week. Next is the maintenance stage, which some consider to be the final stage. This is where the behavior change is sustained greater than 6 months. An individual might say, I am still exercising, or I have been exercising continuously for 6 months. Lastly is the termination stage, which is when there's no desire for an individual to revert back to unhealthy behaviors or relapse. At this stage, the behavior is a regular part of a client's life and does not take much effort or thought. Let's review disordered eating. This is defined by the Academy of Nutrition and Dietetics as used to describe a range of irregular eating behaviors that may or may not warrant a diagnosis of a specific eating disorder. Disordered eating can include a mild, short-term change in eating patterns that could be the result of a stressful event, illness, or attempt to modify the diet. Disordered eating does not mean that someone has an eating disorder, but problematic eating patterns can put someone at risk of serious health problems, and it also may progress to an eating disorder. Eating disorders, according to the National Eating Disorders Association, are serious but treatable mental and physical illnesses that can affect people of all genders, ages, races, religions, ethnicities, sexual orientations, body shapes, and weights. Eating disorders also often co-occur with other conditions. A study of more than 2,400 individuals hospitalized for an eating disorder found that 97% had one or more co-occurring conditions. Eating disorders, while not having a clearly defined cause, can be related to many factors, including psychological, sociocultural, and biological ones. According to NEDA, anorexia nervosa is an eating disorder characterized by weight loss or lack of appropriate weight gain in growing children, difficulties maintaining an appropriate weight for height, age, and stature, and in many individuals, distorted body image. Here are just a few of the signs and symptoms of anorexia. A complete list is available on the NEDA website. Dramatic weight loss, develops food rituals, eating foods in a certain order, excessive chewing, rearranging food on a plate, refuses to eat certain foods, progressing to restrictions against whole categories of foods, no carbohydrates, feeling cold all the time, menstrual irregularities, amenorrhea, irregular periods, or only having a period while on hormonal contraceptives. This is not considered a true period. Fine hair on the body or lanugo. Treatment of any mental illness involves not only the individual, but also family, friends, and a psychiatric counselor. Treating anorexia often involves a registered dietitian who helps to provide dietary solutions that are adjusted over time. The goals of treatment for someone with anorexia are to restore a healthy body weight and significantly reduce the weight obsession and behaviors associated with the eating disorder. Relapse to an unbalanced diet is high. According to NIDA, bulimia nervosa is a serious, potentially life-threatening eating disorder characterized by a cycle of binging and compensatory behaviors such as self-induced vomiting, desire to undo or compensate for the effects of binge eating. Here are just some of the signs and symptoms of bulimia. A complete list is available on the NIDA website. Evidence of binge eating, including disappearance of large amounts of food in short periods of time or lots of empty wrappers and containers, indicating consumption of large amounts of food. Evidence of purging behaviors, including frequent trips to the bathroom, after meals, signs and/or smells of vomiting, presence of wrappers or packages of laxatives or diuretics, shows unusual swelling of the cheeks or jaw area. Repeated damage to the esophagus puts people with bulimia at an increased risk for esophageal cancer. The disorder is also highly genetic, linked to depression and anxiety disorders, and most commonly occurring in adolescent girls and young women. Treatment often involves antidepressant medications and, like anorexia, has better results when both family and the individual with the disorder participate in nutritional and psychiatric counseling. According to NIDA, binge eating disorder is a severe, life-threatening, and treatable eating disorder characterized by recurrent episodes of eating large quantities of food, often very quickly and to the point of discomfort, a feeling of loss of control during the binge, experiencing shame, distress, or guilt afterwards, and not regularly using unhealthy compensatory measures, i.e. purging, to counter the binge eating. It is the most common eating disorder in the United States. Signs and symptoms are similar to bulimia, with the exception of the purging aspect. An individual with binge eating disorder is often at a higher body weight and experiences guilt, shame, and depression. Treatment often involves antidepressant medications as well as nutritional and psychiatric counseling.